There we go. Okay.
Fantastic.
Thank you very much. So revision arthroscopy is becoming more frequent as the number of procedures and surgeons performing them dramatically increase. Reasons for failed hip arthroscopy are multifactorial. We've heard about it: residual deformity, osseous instability or dysplasia, excessive resections with the potential for iatrogenic instability, soft tissue or capsular incompetence, labral deficiency, and adhesions. Psoas tenotomies seem to be performed with less frequency or not at all by many experienced hip arthroscopists. Reasons for psoas tenotomies being performed include recalcitrant internal snapping hip, psoas impingement after total hip arthroplasty, psoas impingement in the native hip, but I think the argument is that there's underlying osseous or soft tissue instability with the psoas trying to stabilize the anterior hip. And then what I would call the shot in the dark, where you're not sure what's going on and you're just trying to do something that might help take care of the pain. So the purpose was to evaluate the results of concurrent or prior psoas tenotomy compared to those without a history of tenotomy after revision arthroscopic FAI surgery. Our hypothesis was that a history of psoas tenotomy would negatively impact outcomes after revision arthroscopic FAI correction, and that increasing femoral anaversion would correlate with poorer outcomes in the setting of a prior or concurrent psoas tenotomy. So between 2007 and 2015, 130 arthroscopic hip revision procedures met the inclusion criteria. 28 of those were previously performed by me. 102 of those were performed elsewhere. So we identified three groups. Group 1 was a revision where they had a previous psoas tenotomy. Group 2 was a revision with a concurrent psoas tenotomy, so that means I did all of those psoas tenotomies. And Group 3 was a revision without a psoas tenotomy, either in the past or at the time of surgery. We had patient-related outcome measures. We evaluated their preoperative hip morphology as well, and radiographic measures using plane radiographs. Femoral version was measured with three-dimensional CT scans. Postoperative radiographic measures were done as well, and we defined a failure as a modified Harris hip less than 70 or going on to total hip arthroplasty. So the surgical procedures: residual cam deformity was corrected, as you can see here on the AP and lateral radiographs. Acetabular overcoverage was corrected, as seen here on your AP radiographs. Subspine deformities that were left, and this is not infrequent, were also corrected, as seen on the AP and false profile views here. Adhesions, which have been described: capsulolabral adhesions, femoral neck capsular adhesions, and with the previous psoas tenotomy, you can also get some residual psoas anterior capsular adhesions. Were taken down with a shaver and a thermal device. Labral deficiency, so more recently performing labral reconstructions when there is previously excised labrum or an irreparable labrum. I only do this pretty much in a revision setting. I prefer to use a tibialis anterior allograft. It's probably 15 to 20% of my revision cases. I use a shuttle technique, but certainly the indications and techniques are evolving for all of us. Capsular laxity or unrepaired capsulotomies. People do talk about capsular reconstructions. I find that is rarely necessary. So either I'll take away the scar tissue between the two ends and do a side-to-side repair, seen at the bottom left, or if the more frequent finding is that the more proximal capsule adjacent to the acetabulum is deficient, I'll then repair the distal limb up towards the acetabular rim with suture anchors. So psoas tenotomies can be performed at the level of the lesser trochanter or more frequently now in the central compartment. So the bottom left is being performed at the lesser trochanter, and the bottom right is being performed at the central compartment. Currently, I rarely perform these, maybe one time a year out of over 500 to 600 arthroscopies, so you can see it's very infrequent for me to perform this procedure now. So results. There were 13 hips in Group 1, had a previous psoas tenotomy. The majority were females. The mean age was 25. The mean lateral center edge angle was 32. Mean femoral version was 20. The preoperative diagnosis all had CAM-type FAI. About 2/3 had pincer-type FAI, and none of them were deemed to be dysplastic. In Group 2, with a concurrent psoas tenotomy, so again, I performed all of these psoas tenotomies in these revisions. There were 22 hips, the majority females. The mean age was 30. the mean lateral center edge angle was 30 degrees. The mean femoral version was 14 degrees. So I think I was careful to look at version when these Psoas Tenotomies were performed. The majority had cam-type FAI, again about 2/3 had pincer-type FAI, and 14% had some dysplastic radiographic features. And in group 3, the group that never had a previous or concurrent Psoas Tenotomy, there were 95 hips. Again, the majority of females, but the ratio was not as high towards females. The mean age was 30, the mean lateral center edge angle was 32, the mean femoral version was 15 degrees with a wide range, and the preoperative diagnosis was the majority cam-type FAI, over 60% pincer-type FAI, and 7% had dysplastic findings. So some of this is power, certainly, but there was no statistically significant differences between groups for gender, mean age, cam deformity, pincer-type FAI or dysplasia, but I would argue that there definitely is a higher prevalence of females in the Psoas Tenotomy group. The numbers just don't give us the power. So in group 1, follow-up 30 months, the failure rate was 50%. In group 2, with a concurrent Psoas Tenotomy, follow-up of 40 months, the failure rate was 50%. And in group 3, with a follow-up 30 months, the failure rate was 25%, and this was statistically significant. If we look at the modified Harris hip score, interestingly, there was no difference for the overall improvement, but what we found is that those with a prior Psoas Tenotomy and those with a concurrent Psoas Tenotomy during the revision had presented with a lower modified Harris hip score or more disabled prior to the surgery. If we look at their most recent modified Harris hip scores, where they end up, it was 80 points for the no Psoas Tenotomy group versus 68 and 71, which is not very good for the other two groups. And femoral version, a little surprising to me, was not predictive of superior or inferior outcomes with regards to femoral version, outcomes, and Psoas Tenotomy. So Psoas Tenotomies were performed more frequently in the past. Some surgeons routinely released the psoas tendon for all cases. There have been increased concern with regards to persistent weakness and postoperative instability. There are a number of studies that show improved outcomes with really no complications or obvious strength deficits. We did perform a study looking at revision versus primary FAI, but we did not evaluate the psoas and whether it was released or not. So this study here, Psoas Tenotomy and femoral version, Sheesh Beatty and Brian Kelly, basically found that their latest post-op modified Harris hip scores were lower in their high femoral version group after a Psoas Tenotomy. Another one here that was recently done looking at persistent hip flexion weakness after a Psoas Tenotomy. They had two groups and at almost 2-year follow-up, 25% in the Psoas Tenotomy group had a significant decrease in the overall muscle bulk, but most importantly, a 19% deficit in hip flexion strength in a seated position compared to 4% if no Psoas Tenotomy was performed. A number of reports showing iatrogenic dislocations after capsulotomies, Psoas Tenotomies, so this is most concerning, but small numbers there. So I think Psoas Tenotomies have successful outcomes in some studies. More recent studies have noted persistent hip flexor weakness, what I see more often, poorer scores with higher femoral version, and iatrogenic dislocations in isolated cases. The current study supports poorer patient-related outcome measures at presentation, higher failure rates, an inferior final patient-related outcome measure with a history of Psoas Tenotomy or a concurrent Psoas Tenotomy with an arthroscopic revision FAI correction. And certainly future studies need to be better define the role for and whether Psoas Tenotomies are indicated for patients presenting with hip-related pain in the native hip. Thank you very much.